The whole picture is kind of complex, and also there's the issue of the words we use or the language we use or the phrases that we use to describe what we're talking about. And so here we refer to this condition as interstitial cystitis / bladder pain syndrome. There is a move afoot, I think, maybe to sever the cystitis phenotype from the bladder pain syndrome phenotype, and there are probably some good reasons to do that. But I'll present some information about all of this stuff, and that's just my way of saying it's really challenging to know where to begin with this condition because there's a lot of unanswered questions. So that's where we started with. And so Dr. Bedlani is a guy that likes to set up big meetings. And so he said, how about if we hold a global consensus meeting in Winston-Salem and bring experts to discuss topics related to all things IC-BPS. And so that's where we started. Let's see, I'm not able to, there we go. There we go. Okay, so the simple meeting agenda goals back in when we talked about this a year ago in October was that to advance the current knowledge, to bring people together that work in this field, and to build on the past efforts to try to come to consensus on some of these concepts, and then maybe not the least, which develop a common language maybe across research teams and across the globe, in fact, so that when we're talking about IC-BPS, we're somewhat on the same page. The stakeholders for this meeting, as we imagine this, are fairly obvious. So the NIH and IDDK would be a primary stakeholder. The MAP network, most of you, I assume, are familiar with. I'll talk a little bit about that. The Essex Consortium, the GIBS, the Asian Japanese groups, and then last but certainly not least, the patient groups that represent, foundations and just patient advocacy groups. So all of these are stakeholders, and all these, we're interested in feedback and input from all these groups. So the first thing that Dr. Bedlani and Evans and I did is have me, we met and talked about this, and then we got in touch with Chris Mullen at the NIDDK, who many of you know. And again, this was October, a year ago, October. And Chris was very interested in helping us with this and so forth. And as you may imagine, by the time January came around, things changed. And so when we got closer to meeting time, it was clear that the NIDDK reps not only could not attend the meeting, they couldn't be associated with it, they couldn't have a name on anything and so forth. But Chris was able to share with us some of his slides. So I'm going to show just a few of those just for some more background. You may be aware, if you're aware of the MAP consortium, this is to look at urologic chronic pelvic pain syndrome, UC-PPS, which includes interstitial cystitis bladder pain syndrome. And you may be aware that this is a largely female diagnosed disorder, about 4 to 1, 5 to 1, females to males. Some of that may be selection bias, or it may be because women visit the urologist more frequently than males, so it may be underdiagnosed in males. But at any rate, that's the going rate. And then chronic prostatitis, which is obviously only male. And so this consortium was set up, I don't know, 12, 13 years ago to actually look at UC-PPS across multiple sites across the US, do deep phenotyping, and in an attempt to understand the similarities and differences, not only in the patient populations, but in regional and on some level, maybe even global differences in inputs into the phenotype, I guess you could say. And so this is another slide from Chris. Why has progress been so slow? So a few ideas that in the field, there's been an emphasis on bladder and prostate as a source of the disorder. And I think now that the MAP has been completed phase 2 of their work and are writing a lot of that stuff up even as we speak, it's become clear that there's a large body of evidence that there are systemic contributions to this. So this isn't strictly a bladder disease of the bladder. It's actually, in many patients, it's a whole body disorder that impacts the bladder. And I'll provide some evidence for our belief that probably there is a bladder-centric subset within this IC-BPS population that truly has a bladder disease. Those are the patients that are characterized by a number of unique findings. And those are the patients, by definition, who are probably most likely to end up having a cystectomy. So end-stage bladder disease. Not all of them, but what I'm getting at is that that's sort of a phenotypic characteristic. And then the majority of patients, maybe 80% or so, we believe, has a different phenotype, more a systemic pain disorder that impacts the bladder in various ways, and certainly there are urologic characteristics, but there are also all sorts of co-occurring pain conditions that come along with this, and non-urologic symptoms and syndromes. So the idea of putting this consortium together, if I understand it, was to bring people together and to get some new scientific approaches and ways to look at this. And I guess at the time it was perceived that there was an insufficient interaction between clinical and basic research expertise. And I will say all the work that I've done in the past several years involves, and again, my other big program is interstitial cystitis, well, interstitial, and the other is autism and GI disorder in children. I wouldn't think of doing either one of these activities without interfacing with clinicians, patients, patient groups, and all that, because physicians, for obvious reasons, they see the patients, they have an inside look at what the knowledge gaps are, what kind of things would really benefit diagnosis and treatment, and what can we do. So that they're a tremendous source of information. The patients themselves, or the caregivers in the case of children, are also just a rich source of information about what sorts of questions do we need to answer and look at. And so that was always sort of obvious to me. And then this, there was a perception and the truth that there was an insufficient involvement of expertise outside of just urology, traditional focus, urology focus, to actually come at a complex condition like IC-BPS from a number of different directions. And I think all of this has been successful. All of it seems rather intuitive right now, but I mean, I think it's borne some fruit. There's still a lot left to do, but, and we'll get into that in just a moment. And then finally, this the focus on patient-centered. In the autism world, they have a saying: once you've seen a child with autism, you've seen a child with autism. And what they mean by that, of course, is each patient is sort of unique. Now, there are similarities. There are subgroups that have more similarities and differences and so forth, but each individual patient is an N of one. And so this focus and move towards sort of a personalized approach, I mean, has merit and has a value. It's not trivial, of course, and it's not easy to do. But if we have a better way to group these patients, I think, into meaningful clinical cohorts, I think it will move the field forward a little bit faster. So the map, again, I think this is the last slide on the map. The phase one ran through from July 2008 to 2014. There were sites all across the United States. And the idea in the initial phase of this was to do a 12-month cohort study and do, as I understand it, deep phenotyping. So you understand pretty much everything you can understand about IC patients, all the characteristics. They use questionnaires, clinical metrics, and so forth. And they did deep phenotyping at baseline 6 and 12 months. And then they had a cohort of roughly equal number of healthy controls, and then positive controls. And in this sense, the positive controls were patients that had one or the other of several of the co-occurring conditions that occur commonly in IC. So like IBS, chronic fatigue syndrome, and fibromyalgia. So those also served as controls. So you could look at those that had just one or the other or of those. Because IC-BPS patients, if I'm looking at those three things, about 30% roughly, it seems like everything's 30% in IC. About 30% of patients will, or more or less, will have each of these, and some will have two of these or all three of these. So we look for 10 or 12 different, or we ask affirmative or negative for 10 or 12 of these co-occurring conditions. And patients with what we're calling the bladder pain syndrome phenotype have on average 4 of these co-occurring conditions, and the ones with the bladder-centric phenotype have on average 0 to 2 of these. So they have much fewer stuff outside the outside the bladder. Anyway, so that was the first phase. And the second phase, it just ended officially 2 years ago, but now I think the data analysis is still ongoing, is a 36-month cohort study. And you can read all about this. And there have been some seminal and phenomenal work published out of the MAP, and it's been nice guidepost for a lot of us. And I got started in ICBPS in about 2013, so just when MAP phase 1 was sort of wrapping up. And we used that, the idea of deep phenotyping, although we didn't do deep phenotyping here, we did a less deep phenotyping, but the same concept. Stratify patients into, or as I see it, stratify patients into clinically meaningful subgroups. And so, anyway, so that was what the idea or the charge for the MAP was. And so all of this information then would support evidence-based clinical trials that would get at finding treatments that actually work in large swaths of patients. That was, I think, the take-home message, the take-home goal. So there was a lot going into this, and the MAP, when in its genesis, they recognized that you have to take a whole picture approach here, and consider a whole lot of things if you actually want to come up with standards that can be applied to the larger ICBPS population. So it's a massive and remarkable undertaking. I was lucky enough to get a ancillary study to the MAP, so I actually got to go and sit in on some of the PI meetings. It was really interesting. But we were looking at, and I'll get to this in a moment, one of the fourth line therapies is bladder hydrodistension. And this is a therapeutic where the bladder is instilled with PBS or water, and it's to capacity, and it's held at capacity for under pressure for 5 minutes or so, and it provides a therapeutic benefit to patients. And the duration of that benefit, like the duration of benefits and all sorts of things that are tried on ICBPS patients, is variable. So it could be from a little bit to a couple of weeks to a couple of months, and it wasn't clear. So the ancillary study that I did, since we do hydrodistensions with some frequency here at Wake Forest, or Bob does, was to look at what is the duration of benefit in patients with ICBPS who undergo hydrodistension. Okay, so taking a note out of the playbook from the MAP, and I wasn't familiar with the MAP, so this was sort of, we came up with this independently, but it was pretty exciting to see that the MAP was doing this. And so once I got this ancillary study, I was able to also access the MAP questionnaires that a lot of them that they had designed, not all of them, but a lot of them. And so I got a sort of a subset of questionnaires that we use. So I didn't do as deep a phenotyping, but we did do pretty reasonably comprehensive phenotyping with a lot of the validated questionnaires, and then some additional things like the pain body map and stuff like that. So our phenotyping efforts have been going on for about, again, since about 2013. And as a molecular person, one of the first things I was going to look at is molecular differences. And so all of our patients in our cohort and in our registry now, we have 700 in the biorepository, if you will. And those 700, every one of those patients has undergone one or more hydrodistensions. So we recruit them. That's a condition of recruitment, or including them in the study, is they've undergone a hydrodistension, at least one. And most patients that undergo one have a tendency to undergo more later, because it provides benefit, but the benefit's relatively short-lived, several months. Anyway, so because we do that, we got to measure that most groups do not get. In addition to functional capacity, we also have actual anesthetic bladder capacity. So for every one of these patients, we have how big is how much fluid can their bladder actually hold. So obviously that's a lot larger than what the functional capacity is. But anyway, it gave us a starting point, and you'd be interested maybe to know that out of the 700 patients, we have a range of anesthetic BC from 150, let's say, all the way up to 1600, and everything in between. So we don't actually have a longitudinal study of anesthetic bladder capacity, but we do have, if you bend bladder capacity by, let's say, in 100 cc bends, you'd have X number at 150 to 250, and X number at 250 to 350, and so on. And you can start to, if you look at molecular characteristics and clinical characteristics of patients within those bins, you might start to see patterns that would be suggestive of phenotypic similarities or differences. And so anyway, we looked at all these, and we published some papers on identification of bladder capacity as one of the metrics to separate or to identify what we call bladder centric versus non-bladder centric. And anyway, so we actually, that gave us an opportunity to do some things that had not been done or published before. And it actually is really interesting because we still don't understand these low capacity patients, and there are a number of them. I would say in our cohort of 600 to 700, about 10% have a finding of Hunter lesion, which those of you in the field are familiar with what that is. Hunter lesion is interesting because only patients that have Hunter lesion on one visit are more likely to have Hunter lesion on a subsequent visit and so forth. The vast majority of patients never present with Hunter lesion at all. So it's one of these interesting conundrums, but in most populations that have been looked at, not everybody agrees with this. So I'll say there's controversy to all of these suggestions, but most studies that have looked at the prevalence of Hunter lesion in whatever cohort they're looking at, whatever part of the country, whatever part of the world, it's somewhere between 10 and 15% is usually what's reported as the number of patients out of the total that have a finding of Hunter lesion. Everybody else does not, and they won't. So that's interesting. I don't know where Hunter lesion comes from. I've been intrigued by that. But anyway, so that, and that also tracks often with what we think of as a bladder-centric phenotype. Not always, but typically. And a lot of the Hunter lesion patients are older, or patients that present with Hunter lesion are older. They have fewer non-neurologic symptoms and syndromes. So Hunter lesion tends to be their primary concern, and you fulgurate the lesions, and typically that provides relief from the pain. Not always, but anyway, that's the standard of care, and that works in a lot of patients. Hunter lesion patients also tend to have smaller anesthetic capacity, and I don't know if that's over time or as a consequence of having lesions multiple times. I mean, again, there's a lot of gray area there, but it's an interesting phenotype, let's say. But we've identified another phenotype that's also low capacity that have never had a history of Hunter lesion. So for all intents and purposes, they look like a bladder-centric patient, but they do not have the Hunter lesion, which is indicative of an inflammatory process that may lead to fibrosis, that may lead to diminishing capacity. Anyway, this was one of the findings. So as we were talking among ourselves about, so what sorts of topics would we want to talk about in a consensus meeting? Obviously, phenotyping came up, so the standardized questionnaires, which ones to use, and so forth. And there are a lot of those out there, and a lot of those that you're able to use. Objective measures, and this is some of the stuff that the map came up with, like the body map, the pelvic floor readings, skin biopsies, et cetera. Phenotyping, as in things like bladder capacity, which is something that we've championed a little bit because it really allows you to do some other stuff. And then the obvious separation between those with and without lesions, and that's been published by multiple groups for a long time. And in fact, a lot of people believe the Hunter lesion phenotype is the interstitial cystitis, and then the non-Hunter lesion phenotype is the bladder pain syndrome. There's debate about that, but anyway, that might be a simplified way to think about it. Biomarkers. This is a really interesting topic, and anytime you're going to talk about a consensus or discussion in the field, biomarkers or markers are going to be something that will come up. If for no other reason, then there are no biologic markers specifically for interstitial cystitis, IC or BPS or IC BPS together. And wouldn't that be interesting if you could go in rather than sort of have to rule out everything else and say, okay, what we're left with is IC-BPS. If you take a blood test or a urine test or a biopsy from the bladder and you do a test on that and you say, yep, it's positive, or nope, it's not positive, and say that's your thing, you have IC or you don't. And then, if you knew something about the etiology, then you could maybe work a therapeutic direction based on that. So markers are still lots of people looking at markers for IC, and I'm not aware of any that are highly sensitive and specific at this point. There are some that have gotten some traction, but to my knowledge, nothing that is definitive. The role of microbiome in urine tissue, and people have looked at microbiome. We've looked at microbiome a little bit, and believe it or not, there's actually bacteria in the bladder wall. So, and we've looked at that and measured that. So you can actually, oddly enough, I mean, we were a little surprised to see it. I work with Alan Wolf, who's somebody that's published on this a lot. We took the mucosal biopsies from IC-BPS patients, and we just did 16S sequencing on about 40 of them. We found, I talked to Alan, what do you expect us to find? And he said, well, it could be, you know, we won't find any bacteria at all in any of them because it could be just bacterial deserts, and you find them in little pockets somewhere in the bladder wall, and you'd be lucky if you do it. Anyway, long story short, we found it in like 37 out of the 40 biopsies. We found evidence of bacteria above background, and we were able to quantify it and so forth. Anyway, the numbers were not large enough to make a determination. Is it different than IC versus control? We had a few IC and control, but anyway, we haven't pursued that further yet. But it was definitely bacteria within the bladder wall residing there. And this isn't UTI type. I mean, it was residing there. What it was doing and what it might later do, it's unclear. But it wasn't the bacteria that's responsible for urinary tract infection. So it's something different. Diagnosis obviously is something that would be on the discussion list for a consensus statement. Idiopathology, this is a really important one because, again, there are a number of potential etiologies for interstitial cystitis, bladder pain syndrome. So we were quite interested in looking at that and pursuing that and having somebody do the lit review on that. You can't have a consensus meeting without talking about therapeutics, which work well, which groups do they work in, and that sort of thing. So there was a topic, therapeutics, oral versus instillation, intraventricular, neuromodulation, which is there's a large part of this population that tries neuromodulation, and in some it works and some it doesn't. I don't think we have a great understanding of that yet. It's not an indicate. I mean, neuromodulation is not indicated specifically for IC-BPS, but a lot of IC-BPS patients. I think the primary indication for this would be OAB, and this isn't a lot of our IC patients, or some percentage of the IC patients, have a neuromodulatory device implanted and actually have benefit from that. So anyway, it's something we're looking at as well. Sharing resources, this is another thing that's going to come up in an international consensus meeting. How do we share information and resources across these multiple stakeholders that I showed in the earlier slide? That was something we were interested in talking about. So developing a registry, and not just like the existing registries, but maybe a global registry. And so we had discussions about that. It's a heavy lift, and it's expensive, and it requires, you know, interested parties and funding and all that sort of thing. So anyway, that was just a opening discussions, if you will. And then Curtis Nickel headed up a committee on looking at patient-reported outcomes, and gave a very passionate talk about that and why it's important, and some suggestions for some of the things that we can be looking at. And then finally, you know, developing a consortium for trials. And you know, the MAP just published a manuscript that was actually part of it, just as almost as a voyeur, rather than someone who contributed significantly. But it was a really nice manuscript looking at describing the types of characteristics of clinical trials for patients with IC-BPS, and accumulation of knowledge from the MAP that could be used to inform clinical trial design. Okay, so again, the last slide from the NIH is ensuring, you know, again, one thing that Chris Mullen wanted to highlight, and one of the things, if you know Chris, he'd always would say at the meetings that he came to, is it's really important to have patient engagement and have a patient-centric approach to doing this. And those of you who treat these patients understand how important that is, and how appreciative patients are when they think they're being listened to. I think that has to do with the high placebo effect in IC clinical trials sometimes, because patients are being listened to and heard and offered therapeutics, and so sometimes that in and of itself is enough to get a positive response, I think. Anyway, so the way this was set up, so from that list of topics I talked about before, we narrowed it down to 10 topics, 10 subcommittees. So back in October, November of last year, we set up 10 subcommittees. We contacted experts in the field, said, would you be willing to head a subcommittee? Would you put together a group, your committee, and then would you include one or more junior investigators who would actually be the ones to write the draft manuscript? And so we got people to agree to do that. And so we had 10 topics, and I'll go through them one by one relatively quickly here, but to give you an idea how this was set up. And Dr. Bedlani had set up, while we were doing all this, an agreement with neurourology and urodynamics that they would publish this as a special edition. But the way it worked out, if you publish with this outfit, you understand, you just submit the thing and they publish them as they are accepted. So it's not really like a bound consensus journal thing, but it is a series of 10 manuscripts that all were part of this consortium or this consensus meeting. And then Dr. Bedlani wrote an editorial, and I'll get to that at the end if there's time, just to give you an idea of what some of the consensus statements and how they bore out. Anyway, so the first topic that was discussed, the first subcommittee. And so the way this worked is the committees were set up well before the meeting. They met virtually for the most part because they're spread out all over the country and the world. Had a few meetings, and they discussed the topic at hand, and then the junior investigators they put together an outline and then a draft manuscript, and then they iterated on that until it was prepared and near ready right before a week or so before the actual in-person meeting. At that point, all 10 subcommittees sent their draft manuscripts to our organizing group here, and then they were sent out to all the people attending the meeting so that you could look at the manuscripts ahead of time. And then when the consensus meeting was held in person here, the idea was each of these 10 manuscripts were given 30-minute presentation time. They talked about within their group what their consensus was and so forth. And then it was open discussion to the entire audience to add or subtract from the consensus that they had reached within their group. And then the manuscripts, we also did one more presentation at the AUA at one of the ancillary meetings at the AUA. And after that, the manuscripts, all 10, were then finalized, sent for peer review, and then published as they were accepted. So the first one was looking at the definition of the diagnostic definition for clinical for use in clinical trials, and this was headed by Quentin Clemens, who, as you may be aware, has headed up the MAP for all these years, and Glenn Warrenberg was the junior faculty member who actually presented the thing. And so basically the objective for them was to develop a consensus on the diagnostic criteria for ICBPS, and what they came up with in their consensus document was what they called a pragmatic and streamlined definition. And I won't read it for you, but it's here in the conclusion. All of these papers, I think, or at least 8 of the 10 are open access, and the other 2 are available, but you may have to use a few of your tricks, but they should all be easy to find. The second manuscript, I was chair of this committee, and it included Toby Shai and Chris Dorian and some others. And then Dylan Wolf is a resident here at Wake Forest, gave the presentation. And not surprisingly, the discussion here was about patient phenotyping. And our objective was to create a consensus document on patient phenotyping in ICBPS. And not surprisingly, we talked about how we have at least broadly categorized patients in the bladder focused and which we call bladder centric, and then a widespread pain or bladder pain syndrome phenotype. And then there are other variable phenotypes that don't neatly fall within one or the other of those 2 categories. And so again, all of these things are open for conversation, but this was what we came up with in terms of what was in the literature right now and what's being discussed right now. The third group was looking at biomarkers in diagnosis and treatment. And again, it's a really interesting topic. Dr. Kuo, who publishes profusely and Dr. Tyagi out of Pittsburgh was the one that gave the presentation here. Their charge was to identify the role of biomarkers in the diagnosis and treatment of IC, and they found, some of the usual suspects, and basically they concluded, and this is about all you can conclude at this point, because the literature, in my view, is all over the place still. I mean, there aren't great, well, we don't have any sensitive specific biomarkers, as far as I'm aware, that are definitive. And so the conclusion is we still need reliable biomarkers, and they would have great value in terms of tailoring therapies and more precise diagnosis. Maybe not missing people that are currently misdiagnosed or not diagnosed at all. The next review was looking at IC-BPS in men, and you might not be surprised to understand that this is a topic of interest, because based on the map work, I mean, IC-BPS occurs in men and women, and as I said at the outset of this, it's diagnosed predominantly in women at a rate of 4-to-1 or 5-to-1, women to men, and so it's understudied, to say the least, in men. There are no specific. They found this group found through the literature there are no treatments for IC-BPS that are specific to men, and so their recommendation is there's a need for more sex-specific research. And again, I guess the prevailing wisdom is that men go to visit doctors including urologists, less frequently than women, and so it could be the case that it's not that it's a 4-to-1 or 5-to-1 ratio. It just could be that most men don't go to be checked out. So now we'll go over to women's specific findings, and this is the gynecologic findings in IC-BPS. And so this document was to look at the role of gynecologic findings, and this group did a wonderful job. They identified five main occurring comorbid disorders in women with IC-BPS, and most of these are the standard suspects: endometriosis, sexual dysfunction, overactive pelvic floor muscle, hormone-associated changes, and then vulvodynia. So most of these are things that we evaluate for in our group right now. So anyway, the take-home message was that it's important to include and look at these things when you're evaluating the larger picture of diagnostic or co-occurring things in patients with IC-BPS when you're developing a treatment plan. Genomics and histopathology, my passion, among my passions. This looked at a consensus document on what's the histopathologic finding, and not surprisingly, if you think about it, there have been a lot of histologic studies that look at Hunter lesion versus non-Hunter lesion, so that was falling off a log easy to come up with. So the Hunter lesion disease, or I see it as HIC, but anyway, Hunter lesion disease, you're going to find, no matter what you do, we did molecular stuff, you're going to find an inflammatory signature, whether you look at the histopathology or molecular biology. And in fact, interestingly, when we do these bladder hydrostensions, I didn't mention that at the beginning, but we collect bladder biopsies from the posterior wall on every patient. So that 600 or 700 patients that I told you are in our registry and have undergone hydrostension, many of them multiple hydrostensions, we get a bladder biopsy or 1 or 2 biopsies. And the initial study that I did in terms of biomarker ID or stratification was to look at what is the molecular signature, if you will, in a bladder biopsy from an IC-BPS patient. And this was a really small study years ago. In 2013, it got published in J Urology. It wouldn't get published in that now because the N was too small, but it was new enough at the time. It was under 20 patients, and some of them were Hunter lesion positive, some were not, and so forth. Long story short, anytime you see Hunter lesion, so when we took these biopsies, the biopsies were taken from the same location, posterior wall, in all patients. Some of the studies are looking at Hunter lesion specifically. For example, we'll actually go to wherever the lesion is, take a biopsy at the site of the lesion, adjacent to the lesion, and so forth. We always took the biopsy from the same place, posterior wall, whether or not wherever the lesion was, and if the patient had lesion, we reported it. but we didn't target that area. And the interesting thing about that is, and now I've done a lot more samples, was that no matter where you take the biopsy in the bladder, you're going to get an overabundance of inflammatory signature in the molecular signature from, let's say, posterior wall, even if the lesion somewhere else in the bladder. So it's kind of interesting that it's throughout the bladder, even if it doesn't appear to be inflamed throughout. So anyway, so the histopathologic and molecular findings are largely based. We're looking for more subtle differences because I said at the beginning of this that we have a phenotypic subgroup that have a very low bladder capacity, let's say below 400 or 500 cc's on average. And they don't have Hunter lesion, and they don't have a lot of other co-occurring things. They're older, they have higher scores on their symptom scales and all that. So they look, for all intents and purposes, like a bladder-centric patient, but they don't have the lesion. So I'm interested to know what the etiology of their trajectory to low bladder capacity is. And if we could determine what that is and maybe mitigate, that might be a way to head end-stage bladder disease off at the pass, if you will. Anyway. Oh, okay. So the next group looked at idiopathology, phenotypes, and ICBPS, and this group was led by Dr. Henry Lai. Many of you know Henry, and actually, I think Henry gave the presentation as well because Max Sandberg is a resident here, and I don't think he was available on the day we do it. Anyway, so what their again their consensus document or their review article looked at the idiopathology of 3 different IC phenotypes. Again, the lesion, the Hunter lesion, the widespread pain, and the low BC. Since Max is on this, he's biased because he came out of my lab. He spent a year doing research here, so I suppose that's why he settled on those 3. There are obviously more, but the take home there is there are multiple ways that a patient can get to a final diagnosis of IC. So that's the take home message there. Therapeutic treatments. This was headed up by Lori Berger. Many of you know her, and then Karis Buford is the junior that gave the talk. Again, not surprising. It's saying management of ICBPS, and this is not surprising to anybody that knows anything about the condition, requires a multidisciplinary approach and multiple iterative sorts of therapeutic attempts and so forth and all that kind of stuff. And once again, you'll see here again, Hunter lesion disease versus non-Hunter lesion are distinct entities that need to be recognized and treated differently. So nothing that we haven't heard before there. Patient-related outcomes, and this is the one that Curtis Nickel was involved in. And those of you that know Curtis know this is a passion of his, and he's been working on this for years and years. He's got a practice in Canada. And this review article addressed the use of patient-reported outcomes, PROs, and ICBPS. And the most important recommendation was to develop and validate better ICBPS specific PRO. And what do you mean by that is, depending on the type of study, or depending on whether you're looking at patient-reported outcomes in your clinic or whether you're doing a research study, that would help decide which types of PROs you're looking at. For example, in research, we often use the O'Leary Sant and some of these other metrics to evaluate pre and post, outcome measures and so forth, or change. And so what this talk was getting at was, we need to be more involved in listening to the patients and what they find as the most important things that they're looking for in a therapeutic. In other words, what outcome are they looking for? It's not, most of these are not what you think of when you think of a cure. You think of they manage, and some manage better than others. And so what's the primary problem you have, and if this therapeutic were to work, what would that mean to you? What would be the thing that you would be looking for to say it worked better, whether it's relief from pain or restored sexual function or any of a number of other things. So anyway, that was sort of the gist of that, I think. And so they had many recommendations here, and that's all in their manuscript. And then I think this is the final one where we talked about the why a global registry is needed. And we had conversation about a comprehensive international registry. And again, it's like map on steroids where you look, across the world, I guess. But we're kind of a far way away from that, I think. And again, there was discussion about it, and it generated a lot of back and forth conversation. But it's a heavy lift, and so we didn't take it much further than discussion phase at the moment. And I'll tell you what, I see the times are getting really close, so I'm not going to go through this. I have this, Dr. Bedlani wrote a consensus document, which was essentially an editorial for this edition. And I'll give you an example. So he did a post-meeting survey, and he asked 17 questions, and I'll give you just an example. So for the current time, the name should remain ICBPS. This is something bone of contention. Not everybody thinks some people think they should be separated. So apparently 90% of the participants in this meeting agreed that the name ICBPS should be retained. And somebody, a little bit of a snarky comment, but somebody said this constant name change creates confusion. And I don't disagree with that, but nomenclature in this field and any other field where you have complex stuff requires some standardization so that when we're talking about things, we're all talking hopefully about the same thing. And it can be really challenging when you use different, like Hunter lesion disease versus if you use that acronym or you use HIC, Hunter lesion ice, those kind of things. Anyway, and there are another 16 of these, which I won't go into them. I think we're 5 minutes until the hour ends. So I think I'll open it, if that's okay. I'll just open it to questions because you may have a question or two, and I hate to not be able to answer some. So I'll stop there.